We're going to talk a little bit about, first of all, the AUA guidelines and how it approaches nephron-sparing surgery, radical nephrectomy, and the recommendations for genetic counseling. We'll then talk about an algorithm for management of local recurrence, some updates in terms of use of MRI with IV gadolinium in the context of renal failure, and then robotic partial nephrectomy for stage T1B and the neoadjuvant versus adjuvant options. So according to the American Cancer Society, kidney cancer has 81,000 new cases. And 25 years ago, there was an exponential rise with the advent of imaging with greater than 50% detection. In the last decade, it's really started to plateau off for the detection of small renal masses. I think that CT scan and MRI seem to be an extension of physical exam these days in the emergency room, and I think that's probably why the detection with the advent of imaging has been so high. There have been 14,000 deaths, and 85% of kidney cancers are renal cell carcinoma. Now, there's been a lot of interest in looking at racial disparities in the histology. And what we found is that African Americans, in fact, have a twofold higher incidence of papillary renal cell carcinoma compared to Caucasians, and type 2 papillary RCC being more prevalent. But what has also been very interesting, and our institution has had an interest in looking at Native Americans and Hispanic Americans who have a threefold higher death rate for renal cell carcinoma compared to Asian and Pacific Islanders. We published the clinical and molecular characteristics of renal cell carcinoma and noted that in Hispanic Americans, as well as Native Americans, kidney cancer presents at a younger age group, aged less than 50. Native Americans, even younger, aged 20 to 49. And it's hard to know what really leads to this epidemiological finding. I don't think that it's just access to care. It's probably multifactorial. In terms of obesity in the younger generations, it may be a higher, we know that the risk factors of renal cell carcinoma, smoking, obesity, exposure to some aniline dyes are probably all play a role, but I do think there may be a genetic aspect to it. Now, the AUA guidelines, in talking about nephron-sparing surgery, really states that for clinical T1 masses, size less than 4 centimeters, partial nephrectomy should be prioritized whenever intervention is indicated. And there are imperative indications, certainly, in terms of solitary kidney, bilateral tumors, von Hippel-Lindau disease, pre-existing chronic kidney disease, or proteinuria. We know that 80% of renal masses will in fact be renal cell carcinoma, and 20% are benign, whether it's oncocytoma or angiomyolipoma. And that 15 to 20% of clinical T1A tumors are in fact high grade. They'll be upgraded from T1A to T3 if they invade into the renal sinus. Now, the recommendations from the AUA on radical nephrectomy really have really focused on renal function. Now, certainly, it's a balance between oncologic priority and nephron-sparing surgery. So with radical nephrectomy, the sentiment is that when patients have increased oncologic potential, as suggested by tumor size, then a radical nephrectomy should be done. But it should be balanced with the following criteria. If there's high tumor complexity and partial nephrectomy would be challenging even in experienced hands. If there's no pre-existing chronic kidney disease or proteinuria, the patient should have a normal contralateral kidney, and the prediction should be that the baseline GFR after nephrectomy should be greater than 45. And if all of these criteria are not able to be achieved, well, then partial nephrectomy should be considered in this population. So the principles related to partial nephrectomy really balance renal function and oncological efficacy. We want to optimize nephron mass preservation and avoid prolonged warm ischemia. We try and limit the clamp time less than 30 minutes, and negative surgical margins obviously should be a priority. But in those rare instances where local recurrence occurs, we propose an algorithm for management of local recurrence. So There are really three options. If the patient presents following partial nephrectomy with a enhancing mass on imaging, one can either do a completion nephrectomy, ablation, or redo partial nephrectomy. Now, the pros and cons of each. For completion nephrectomy, certainly the advantages from an oncologic standpoint is that the benefits minimize. If you're doing a completion nephrectomy, the chances of any local recurrence of the kidneys, if the remnant kidney is gone, has been optimized. But the patient then, as a con, has a solitary kidney. With ablation, redo ablation is certainly possible, and one can ablate multiple times. I believe, and personally, the failure of ablation is the technical placement of the probes. If the mass is close to the hilum, there can be a heat sink effect. I think the technology works. If the probes puncture the collecting system, however, there's a higher risk of a fistula developing. And we know that size greater than 4 centimeters for ablation leads to greater potential of cracking of the ice ball or bleeding. Now, certainly, redo partial nephrectomy has an oncologic benefit if there are negative margins and preservation of renal function, but is also very technically challenging. Going back into a hilum that's been previously dissected, the adhesions that exist there's a higher potential for complications, whether it's a pleural injury or fistula. Now, Bratzlaffsky reported in the Journal of Urology a series of open patients who had undergone management of local recurrence in an open fashion. This was in a von Hippel-Lindau population with 51 repeat partial nephrectomies in 47 patients. 10 of 51 of these patients were for a local recurrence. Had an impressive disease-specific survival at 56 months. 46 out of 47 of these patients were alive, with on median average of 7 tumors being removed, anywhere an average size of 3.5 centimeters, but 55 millimeters is the spectrum. Jihad Kaouk of the Cleveland Clinic reported on his series of robotic redo partial nephrectomies, 12 tumors in 9 patients, with intermediate term 8.3 month follow-up. At our institution, Chris Morrell, our resident, reported on 8 cases that 5 of which underwent robotic radical nephrectomy, 3 underwent redo robotic partial nephrectomy with an average warm ischemia time of 25.5 minutes. The time to recurrence when these patients had undergone initial resection was 5.1 months. Some were referred from an outside institution for positive margins in 2 cases. One case had lymph node metastasis and an average disease-specific survival of 49 months. Now, focusing on renal function, in that series, the open series, 51 repeat partial nephrectomies in 47 patients, the average ischemia time was 31 minutes, but certainly with open partial nephrectomy and cold ischemia with packing of the ice, they've had the spectrum of their ischemia time went as long as 136 minutes. The creatinine, surprisingly, only went from 1.16 to 1.35. The creatinine clearance didn't change much, 84.6 from a preoperative average of 95. And 2 patients did, however, progress to dialysis. Jihad Kaouk, in his redo series, 33 were for solitary kidney with an average ischemia time of 17.5 minutes. The GFR only had a 7% decrease. He did a different technological aspect where he clamped the hilum in block with a Satinsky clamp. At the University of Arizona, Chris Morrell reported on 8 cases. As I said, the average ischemia time was 25.5 minutes. The baseline creatinine was able to be preserved at 3 months, 1.17, went to a 1.23, and the baseline GFR only had about a 16% decrease. In terms of complications, in the open series, the average time of surgery was an impressive 7.5 hours. The EBL, 1,800 cc's. These are really quite complex surgeries. 33 out of 51 patients, in fact, required transfusions. There were some significant major complications. 11.8% progressed to hemodialysis, had some form of temporary hemodialysis, pulmonary embolus, pancreatic leak. 3 patients lost their kidneys. Fistula occurred in 15.6%, but a host of potential complications were seen in this study. Pleural injury in 17%, renal vein laceration 2, renal artery transection in 1, duodenal injury in 1, and ureteral transection in 1. In the Cleveland Clinic series, the average EBL was 150 cc's. At the University of Arizona, the average surgical time was 2 hours, 34 minutes with an EBL of 200 cc's and a length of stay of 1.5 days. So our proposal of algorithm would be first, certainly review the pathology report. Our average positive margin rate is less than 7%, which carries about a 17% local recurrence risk. In that situation, one would increase the frequency of imaging. Instead of 6 months, 3-month intervals for CT scan or MRI. And if there is a suspicious lesion, we would recommend percutaneous biopsy to confirm histologically. There have been reports in the literature that completion nephrectomy was performed, and when they looked at the remnant specimen, there was no tumor in the specimen. So one certainly wants to confirm histologically that recurrent cancer is there. And then a discussion of risks of redo partial nephrectomy, completion nephrectomy, or ablation. At the University of Arizona, we've seen quite a change in the surgical approach for kidney cancer over time. Back in 2010, the majority were being done open, that's seen here in blue. Then laparoscopic cases seen here in gray probably had the peak at 2013. When I came as chair in 2016, you can see in orange the rise of robotic cases and the decrease in open that really now single-digit percentage points. Really, in this day and age, open surgery for renal cell carcinoma is really being done as a caval thrombus by Dr. Cipollini. In our series, in the last 442 patients, you can see that the average tumor size for partial nephrectomy ranges up to 11 centimeters from a robotic approach, with an average size of 3.4 centimeters. The ischemic time is 18.2 minutes, with a length of stay at the time of this publication of 2 days. We've now gone down to 1 day in the last 3 years. And it's really been, this was mentioned earlier about the rise of robotic approach. Back in 2016, robotic prostatectomy and sacrocolpopexy were being done at our institution. In 2017, we added robotic partial nephrectomy, pyeloplasty, and nephroureterectomy. With the arrival of Dr. Cipollini, robotic cystectomy was offered to our patients. In 2021, robotic upper tract reconstruction with Dr. Kim offering for strictures of the proximal ureter. He has the ability to do a buccal mucosal free graft harvest to perform as a free graft for strictures, lengthy strictures of the proximal ureter. He can use appendix as interposition for strictures, as well as offered patients who have transplant kidney strictures or even ureteroenteric strictures, a robotic approach to treat their strictures. And Dr. Twist has added robotic hysterectomy together with sacrocolpopexy as the most recent addition. Now, in terms of recommendations for genetic counseling, the AUA states that patients that are young, and the definition of old changes every year, but patients less than 46 years old, multifocal or bilateral renal masses, or those who have a first or second degree relative with renal cell should get genetic counseling. Historically, there used to be concern in MRI with IV gadolinium with renal failure because of a concern of pulmonary fibrosis. This is no longer the case. MRIs can be obtained safely, even in patients with chronic kidney disease or end-stage renal disease, based on recommendations from the American College of Radiology. In terms of indications for lymph node dissection, size greater than 10 centimeters, stage T3, T4, high grade 3 or 4 sarcomatoid features or tumor necrosis, but really lymph node dissection is primarily for staging purposes. There's really not a survival benefit for lymph node dissection undergoing surgery for non-metastatic renal cell. The sentiment on adrenalectomy has also changed. We used to always say with a radical nephrectomy, the adrenal should be taken, but and when there is adrenal involvement, that bumps it up to stage 4 and relatively poor prognosis. But if it's a lower pole tumor, if imaging doesn't suggest any involvement of the adrenal gland, one can really spare the adrenal gland. And so that is something that has really changed in the last several years. So in terms of stratification, post-partial nephrectomy after surgery, low risk would be considered T1 or grade 1, 2. Intermediate risk would bump it up if there was grade 3 or 4 or T2 any grade. High risk would be considered T3, pathologic T3 any grade, and very high risk certainly pathologic T4, N1 disease, sarcomatoid rhabdoid, or positive margin. We published several years ago our series of patients for T1B tumors, that is size greater than 4 centimeters, between 4 and 7. 91% of these patients were for elective surgeries. Our average ischemia time was 22.8 minutes. And looking back at the evolution, now in the last 8 years or so, 32% of our partial nephrectomies are now being done for size greater than 4 centimeters, between 4 and 7 centimeter tumors, with an average ischemia time of 20.6 minutes. This is an example of a T1B tumor. This is a 26-year-old female student of environmental toxicology who was referred with an 8 centimeter lower pole mass. You can see that this is a distortion of the collecting system as well as the ureter. Just to orient, the head is to the right, the feet are to the left. This is lateral, this is medial. The ureter is identified, it's elevated. We then dissect out the renal artery. We actually leave the renal vein open. One can see here the renal artery being identified. Here's the vena cava. Here's the bifurcation of the renal artery. Pulling back the gallbladder, it comes into view. The duodenum has already been cochlearized. We then use intraoperative ultrasound to localize on this tumor to assess margins as well as depth of invasion, proximity to the collecting system. We open collecting system in 50% of our patients. The goal is negative margins. We then put a bulldog clamp on the renal artery, leave the renal vein open. We then excise with a cold excision. Now, if this were a hilar mass, we would essentially dissect down into the renal hilum, all the way down into the renal sinus, and not clamp until we were already down into the renal sinus. Then there's a cold excision. The collecting system is wide open right here. If there are any segmental vessels, we place a Hem-Lock clip in order to minimize the risk of a pseudoaneurysm developing. We then complete the resection. The base of the lesion is then closed with a 2O vicryl on an SH needle. We run, essentially this brings the defect together as well as addresses any segmental arteries. We then close the capsule using the sliding click rhinorrhaphy, actually popularized by Sam Bayani at WashU St. Louis. This brings the capsule together. We unclamp and allow reperfusion to take place. And one can see here the remnant kidney there. So afterwards, you can see that 50% of the kidney was preserved, and this patient's now over 5 years out. We also published almost a decade ago now, new adjuvant tyrosine kinase downstaging in T2 renal cell carcinoma and a solid kidney before robotic partial nephrectomy. We know that for metastatic renal cell, 20 to 40% with localized disease will, in fact, develop metastasis after nephrectomy, and a third of patients can present with metastatic disease, and the majority will be candidates for systemic therapy. There's been a relative explosion. 7 drug treatments for advanced RCC, cytokines, IL-2, and interferon really has because of the pulmonary edema and symptoms has really decreased in its application these days. Tyrosine kinase inhibitors, sorafenib, sunitinib, pazopanib, axitinib are still have a role. Where it's really changed is towards the immunotherapy, anti-VEGF, mTOR inhibitors, the PD-1 inhibitors, nivolumab, pembrolizumab, as well as the CDL4 inhibitors have really, I think, taken the lead. In the treatment algorithm for favorable group, our medical oncologists, there are a number of preferred regimens. Our medical oncologists prefer nivolumab, and Cabo or Pembro and axitinib. For intermediate risk. Ipi-Nivo is certainly their preferred regimen, but there are a number of options. These are the options for immunotherapy naive and prior immunotherapy. So the algorithm really for renal cell, size up to 21 centimeters, multifocal disease, non-amenable, renal vein thrombus, they'll be directed towards radical nephrectomy. Technically resectable lesions of any size, less than 11 centimeters, endophytic lesions that are able to be localized with ultrasound, solitary kidney, renal insufficiency, bilateral disease with good performance status will be directed to robotic partial nephrectomy. If there is concern that surgical resection would compromise renal function and result in a GFR less than 30, the consideration for neoadjuvant immunotherapy. If there's severe cardiac disease and morbidities, the patient will be directed towards the ablation modalities. So thank you very much.